Why don't we talk about contract pharmacy restrictions?
All right, I think it makes most sense to start with kind of where the history of contract pharmacies. So the 1992 340B statute actually doesn't say anything about contract pharmacies or pharmacies at all. It states that covered entities are able to purchase 340B priced drugs and provide them to their patients to help stretch scarce federal resources as far as possible. We didn't get the concept of contract pharmacy from HRSA until 1996 when we got guidance that stated that covered entities that didn't have any in-house pharmacies could use one contract pharmacy to be able to dispense prescriptions to their patients at a 340B price or extended the 340B program into that contract pharmacy. And we also got from that guidance some criteria that were suggested aspects of agreements between a covered entity and a contract pharmacy. So in 2010, HRSA provided additional guidance around contract pharmacies that really brought us more to the concept of contract pharmacies as we know them today. Instead of only covered entities that didn't have an in-house pharmacy being able to access contract pharmacies, any covered entities could utilize contract pharmacies to be able to extend the 340B program into the retail pharmacies in the community that served their patients. So it was no longer just one pharmacy, it was the pharmacies that served the covered entities' patients, and it was then for any covered entity to participate in. They got there because they did studies and research to see from the covered entities that originally started with a single contract pharmacy, the additional benefit that it brought to the patients in that community.
So one of the things that's often overlooked in how did we move from a single contract pharmacy to actually working with the pharmacies that serve our patients is that the original guidance alluded to the fact that HRSA was going to be looking into this. So they said, yes, right now you can only work with one, but they had the intention of actually exploring the opportunity for covered entities to work with the pharmacies where their patients were receiving prescriptions. So between the 1996 guidance and the 2010 guidance, they actually came out with what was called alternate demonstration projects. And so there were a number of covered entities across the country, including federally qualified health centers, who participated in these projects. During that time period, they went under a lot of different HRSA audits to test the model to make sure that the compliance was there so that when the model was expanded across the country, that HRSA, Congress, the Office of Pharmacy Affairs could be sure that compliance was there for the covered entities. And so we all can be very appreciative of the health systems that actually participated in what they are abbreviated to as ADMs, and the fact that they were tested so thoroughly over that long period of time.
So how do we get from the 2010 guidance on contract pharmacies to where we are today with manufacturer restrictions? What happened between those two times?
Yeah, so it's really interesting, right? So 2010, we had the contract pharmacy guidance, and what we saw was a number of covered entities who had not really participated in the 340B program now saw an opportunity to really serve their patients and meet them out in the community where the need was and where patients were actually filling their prescriptions. And especially for small health centers, it's a big barrier to try to open up your own entity-owned pharmacy. You may not have enough patients to support you having one on your own, but being able to access it through the contract pharmacies where your patients were already going made a lot of sense. We also saw the rise of the third-party administrator, or the TPA, who helped facilitate that process. So between 2010 and 2020, we saw a growth in the number of covered entities who were participating in the contract pharmacy programs. In the middle of that, we had what was called the orphan drug rule come out. That was challenged by the pharmaceutical industry, and the orphan drug rule in the court cases was overturned. HRSA then later came out with a guidance which mirrored what was in that rule. That was also challenged, and that had to be walked back. Ultimately, what came from that court case is the fact that items that are published in guidance do not have the binding authority of law. And so guidance helps us understand where the federal agency that regulates a program interprets the statute to go, but it doesn't create law in and of itself. And so where contract pharmacy sits in guidance, it creates an opportunity for interpretation. And where contract pharmacy is not mentioned in the statute, it creates an opportunity for challenges, as well as we've seen in 2 of the recent court cases that have come back from the Third Circuit and the DC Circuit, an opportunity for manufacturers to potentially impose what are considered to be reasonable conditions on the sale.
Recently, we've seen a new evolution in manufacturer restrictions where manufacturers who had previously allowed access to 340B pricing at all of a covered entity's contract pharmacy if they were willing to submit claims data, as well as those that had allowed a single designation without submitting claims data, moving to a model where they allow designation of one contract pharmacy, perhaps within a 40-mile radius, but also needing to submit the contract pharmacy's claims data, which has created a real tough decision point for covered entities that had initially chosen to only designate contract pharmacies because they were uncomfortable sharing that claims data.
We've seen a lot of covered entities who are still appropriately concerned about sharing PHI, and the prescription number associated with claims is considered protected health information. We've also seen, most recently, new fields being added to the data request, and those additional fields, can continue to be additional to what may be considered PHI when being provided. Information about who's the prescriber, information about what's the plan, and so there are questions that covered entities are asking about whether or not they're going to choose to participate in this designation plus data sharing model.
Another change we've seen is some of the manufacturers expanding, not only allowing the designation if your entity doesn't have an entity-owned pharmacy. They say you can designate a contract pharmacy regardless, but if you have an entity-owned pharmacy, not only are you going to send us your contract pharmacy claims data, but you're also going to send us your entity-owned pharmacy claims data, which presents even more concerns for covered entities about what data they can and should be providing in the name of transparency when there are, other aspects of compliance at play.
I think this is a great point for us to pause and say, how did we get here, right? And why are we seeing all of this evolution, and what has caused it, right? We talked about the history of contract pharmacy. We talked about the fact that it sits in guidance, and so that creates this opportunity for the manufacturers to create their interpretations. But we've also seen that those 2 court rulings, the DC Circuit and the Third Circuit that have come back, emboldened manufacturers to what they felt were reasonable conditions. The interesting question that we have now is, are these conditions reasonable? The one that we have seen most recently, where the number of fields being asked for by a manufacturer has doubled, has essentially created a scenario where many of the elements that they're providing are not accessible. So thinking about the drug information that would tie to track and trace, and the products being the product serialization, that is something that there are a lot of concerns about. One is, are you able to get it from your wholesaler? And we are not even in the time period yet where it is being enforced. The second is that the law that created track and trace does not have a federal requirement for that serialization to go to the patient level. So we're being obligated by a manufacturer to provide data to them when we don't have a federal requirement to tie that information to the patient. So how are we going to get this information and be able to provide it back to the manufacturer is a new challenge. We've seen that many third-party administrators have said that they're not able to do so. And then another interesting question that's come up with that manufacturers ask is, providing the payer information and whether or not we are able to do so, right? We have visibility into what's happening at the contract pharmacy.
Sometimes, depends on the contract pharmacy and the TPA. We don't always have visibility into who the payer is.
At the claim level.
At the claim level. We do usually have visibility into the reimbursement amount. However, there are concerns contractually between the covered entity and the 340B ESP in providing that information. Is the covered entity able to provide that information based on their contract with the contract pharmacy? Then there are also concerns from the contract pharmacy standpoint, their obligation to their payers, the contracts that they have with the insurers, may prohibit that information from being shared as well. So there are multiple layers to the new data fields that are being requested that are causing covered entities to pause, ask more questions, and figure out how do we get this data? And also, is it okay for us to share this data?
Yeah, and the hard part for covered entities, right, is what do we do about it? Because, and if you enjoy 340B in the courts, right, there's a couple times so far that it's been to the Supreme Court. One of those is AstraZeneca versus the County of Santa Clara. And in that Supreme Court ruling, it established that the covered entities, we don't have a legal right of action against the manufacturers around the denial of the 340B price. And so we are not able to sue a manufacturer when we deem that they're out of compliance. And so our pathway is through the administrative dispute resolution process, which the Office of Pharmacy Affairs and HRSA just recently published a new guidance, and they're still working through the process of bringing that live. So the challenge being that, we can't take it to court to say, we consider these conditions to be unreasonable, and how do we manage that? And what we've been seeing in a lot of the states is that they have taken that to their state legislature and have come up with some really great state laws that are not addressing the 340 price calculation, but are addressing delivery where the 340 statute is silent, but the state has historically had regulatory authority and ability and has been able to create laws around delivery as well as around pharmacy, and we've seen really great success.
As these manufacturer restrictions have grown, both in the number of them, we went from one manufacturer to 10 to 15 to 30. It's increased in number so drastically, but also the scope of the medications that they encompass, as well as the types of covered entities that are impacted by them. Specifically, more of the restrictions applying to grantee covered entities. This has had a really significant impact on the financial stability of our safety net healthcare providers.
That's been really hard. We work with a lot of health centers as well as critical access hospitals across the country, and the challenge that we're hearing directly reported back to us is just how this is impacting their financial viability. For some, it's the question of whether or not they're going to be able to keep their doors open. As a health center in general, we had a call last week with a client that was the question. Actually, they became a client after the end of that call because they weren't sure how they were going to stay in business if they couldn't stabilize the way their 340B program was operating. Others were seeing that as the manufacturer restrictions have been coming into effect over the last 4 years, the revenue that they were able to generate previously from the program and apply to areas of the health center that were not able to cover costs. So, caring for their uninsured patients, offering supportive care, things like their food banks, those are really contracting, and the viability is just becoming more and more difficult every single day.
I've seen from some health centers, they've had to cut healthcare for the homeless, things that aren't reimbursed separately. Some of their mental health care programs or substance use disorder support, because those were so heavily funded by the 340B program and the savings that were returned back into the covered entity to then be able to provide additional services to the community.
Really concerning. This week, I also learned about a couple health centers that, because of the contractions, had to do some significant layoffs. And that's going to impact the patients that they care for, the communities that they serve. And so the concept of, the manufacturer restrictions at the contract pharmacies not harming patients because they're still able to access medications by filling the prescription at the pharmacy is a real fallacy, because yes, they may be able to receive the prescription at the pharmacy, but it may or may not be affordable. and the care that they're receiving from their health center is going down in quality because the health center is becoming more and more underfunded as time passes. I know you've seen some challenges too with patients and the access that they're seeing at the contract pharmacies with the restrictions.
Yes, we've had a number of clients reach out as patients are calling the health center to say, I can't access my medication anymore. I used to be able to purchase it at this price. And they just told me it's $300. And it's so heartbreaking because there are some of the restrictions that we can't navigate through that with. There's not a way around it for some of them. The pharmacy is outside of a 40-mile radius, and there is another pharmacy for the health center to designate within a 40-mile radius, so they can't designate that one out that lies outside. And those patients are going without their life-saving medications in many cases. Or, initially, when all of this began 4 years ago, we were looking at therapeutic alternatives and changing patients from one medication to one that wasn't impacted by manufacturer restrictions. But at this point, they're rolling in so quickly and changing so fast that it's not sustainable, and it's not safe for the patients for us to continue to look and say, okay, this month, this medication is not restricted, so they can get this at the 340B price through their pharmacy, but it may not be available next month. You don't want to keep changing the medication the patient's on every month.
And I think one of the things that's hard is that many health centers are looking at opening their own pharmacy as a way to solve that problem. And when you are a larger health center, that is a really great solution. And when you're a smaller health center, if you only have 3,000 to 5,000 patients, and if you serve a higher population of uninsured or underinsured patients, the financial viability is really not there. So the way that you had created access for your patients was at the contract pharmacy. And so the place where patients were getting affordable medications isn't necessarily an option for those small health centers. And so now we're in this catch-22 of how do we make sure the patients get the treatment that they need in a way that they can afford.
I think that's a great segue into the discussion of what are covered entities doing to help mitigate the challenges and the losses related to these manufacturer restrictions. And the first one, I think that you brought up is a great one to hit, is opening an entity-owned pharmacy, which is a great option for larger healthcare organizations, but really challenging for the smaller ones. But let's talk a little bit about the benefits of adding an entity-owned pharmacy, but maybe some of the challenges of having to go through that process.
And I'll say full disclaimer, Chelsea and I are both pharmacists, so we are super biased to the value of pharmacists in the health center. And so, having the pharmacy embedded in the health center, it does create a great access point, both for making sure patients have affordable medications, because we do ensure that the patient doesn't walk away without care, and can work directly with the team that's in the health center, making sure that if something isn't affordable, that there's another option that's selected that day, but also just being part of the care team, being embedded in the health system to be able to help manage more complex conditions, to be able to help educate the providers. And really, one of the things when we worked at our health center was helping build the confidence of our prescribers to deliver care that they might not have otherwise. A couple areas where the pharmacists were heavily involved in doing that work was the management of hepatitis C and the management of substance use disorder. And the work that we were able to accomplish there, because pharmacists were involved, was very different from what we did before the pharmacists joined the care team. So the entity-owned pharmacy, hugely beneficial for making sure your patients have medications, but also hugely beneficial that your care team can help select the right medications and give a broader access to different types of care.
I think one of the other nice things is that obviously the in-house pharmacies aren't impacted by the contract pharmacy manufacturer restrictions, so you have access, full pricing access to 340B medications there. But you also have the ability to provide more above and beyond services within your own entity-owned pharmacy. So you can provide, direct prescription assistance programs through manufacturers or through organizations that provide those, where typically a patient would have to send away for the medication, wait a while, have it sent back to their house, maybe get lost in the mail, who knows? And instead, you can run that program through your pharmacy. They can pick it up just like it's a regular prescription. There's no stigma around not being able to afford the medication. They get it just like everybody else does and in a very timely manner. You can also offer some medication reconciliation services. We've seen vaccine clinics, some chronic disease state management clinics to help support. We've seen anticoagulation clinics, just much more accessible than having to go through the provider once they're stable on a medication. So I think you can add a lot of additional benefit and clinical value to the covered entity or to the health center itself by having an entity-owned pharmacy.
Yeah, we're actually starting to see too within health centers more collaborative visits where the pharmacist is seeing the patient along with the other healthcare professionals, might be with a physician, a nurse practitioner, and just the value of having the two professions in the room and the care that the patient's receiving is so enhanced. Thinking about that entity-owned pharmacy, if you're a tiny health center, it may be out of what you're able to accomplish, but mid-size health centers, the larger health centers, if you're not already doing it, it's definitely something that's important to consider, not just as a way to address the restrictions that we're seeing at the contract pharmacy, but also just as a better way to serve your patients.
I think one of the things to keep in mind when thinking about this, particularly as it relates to the contract pharmacy restrictions, is that this is not a quick fix. You opening up an entity-owned pharmacy isn't going to be an overnight thing. You're not going to be able to, reestablish access to those 340B prices tomorrow or next week or next month. It is likely a year in the making.
6 months at best.
Yes. So it takes some time, but if it works within the structure and the mission and intent of your organization and you have the funds to invest into it, it really can improve the care for your patients and also the sustainability of your 340B program. What about covered entities that already have an entity-owned pharmacy? What can they do to help kind of, stem the bleed, so to speak, that's happening from the manufacturer restrictions?
What I would say is that we've seen quite a bit of work there, right? Because a lot of times the entity-owned pharmacies may have run very restrictive 340B programs. Maybe they only filled prescriptions for their patients when they were written by their providers. And so seeing that they start considering referral prescriptions or even going so far as looking at the continuity of care and having a patient definition within their policy that is able to go through and describe how they maintain responsibility for care across the patient's continuum of care as the primary care provider. And so when they have that broader view of the patient that really mirrors how healthcare is delivered and how the patient interacts with the health center as a patient-centered medical home, they're able to deliver better care to the patient, better access to the medications that they need. But it also means that for the uninsured and underinsured, they're able to get the low-cost medications for both prescriptions written by their providers and their specialists, discharge medications, but also for those who are insured, it creates a source of revenue that helps fund other services in the health center. So by going from that very restrictive 340B definition, looking at only ones written by your providers, to really treating your patient as a human, right? Holistically, that's right. And treating the whole patient, which is what we should be doing. The pharmacies are able to make sure all of the patient's needs are met. And it does help create some stability within the organizations and better access to care for those who are in the underinsured and uninsured population.
I think another thing that entities with entity-owned pharmacies can do, now it seems a little redundant, but here we are, is look at the prescription retention. I know we look at within the 340B program, how many of the prescriptions are being captured, making sure that you've got the contract pharmacies that your patients are already going to included in your 340B program, but really looking at what is being filled in-house. And you by no means want to direct a patient and tell them that they need to use the entity-owned pharmacy, but increasing education for your providers, for the staff at the check-in desk, and for patients about the 340B program and the benefit that it has to the community, to the patients, to the health center, and the other services they can access through that pharmacy. Really can help drive a little bit more traffic to that pharmacy and increase the benefit that you're already getting from having an entity-owned pharmacy.
Yeah, and we've seen a lot of the health centers with their pharmacies get creative, right? Things like adding delivery so prescriptions are more convenient to their patients. Thinking about what other types of services are being offered in the pharmacy or by the pharmacy, so increasing access to vaccines. Talked to one health center that they're doing spirometry with their pharmacists, which is new and different, right? So just really thinking about what are the different types of services that can be provided to your patients, and how do we, again, as you said, right, encourage our patients to view the pharmacy as another part of our health center and part of that care team that serves them.
Outside of an entity-owned pharmacy, if a covered entity already has one and they're already making the most of it, or it's not feasible for them to open one up, let's talk about what covered entities are doing to be able to, do what they can within the contract pharmacy manufacturer restrictions.
It depends, right? Some of the covered entities that we work with are participating in all of the restriction programs, so providing data or doing the data sharing processes. Most of the entities that we work with have opted for designation. I would say that's probably the majority is sitting in the designation only. And that has worked really well. Now that we're seeing more of the designation manufacturers also wanting data, those covered entities are making decisions about whether or not they will provide data or whether they will stop using those manufacturers. And really thinking about too, have we had a shift in where our contract pharmacies are? We've had a lot of changes in the pharmacies that covered entities are contracted with, because as the restrictions have come in, the pharmacies that are viable has become less and less. And so we have had a lot of contracts that have been removed. Also, reassessing where are the patients going today and meeting the patients at those pharmacies to be able to process their prescriptions there and make sure that they have access to affordable medications.
I've also seen, less and less now because the manufacturer restrictions continue to expand, but seen, clinical prescribing changes where possible to medications that aren't under restrictions. So this is really challenging within some disease states where it seems like at this point there aren't any viable alternatives, but I have seen still some continued push for clinical prescribing changes based on what medications are not restricted at this moment and which ones patients can continue to access through that 340B program at the contract pharmacies.
We've talked a lot about the manufacturer restrictions and how covered entities are working to address them. But what we have seen is that every time a covered entity is making a change, then manufacturers are also adapting. The formulary changes have had many covered entities shift to use a single manufacturer that was left in the market, and then that manufacturer feel compelled to also impose restrictions, even though they were later to the restriction game than others.
It's getting harder and harder to make the best out of a bad situation.
Yeah, everything has the cause and effect. The manufacturers make a change, covered entities respond, manufacturers respond to that. What we have seen be the most successful is the state regulations. We have a number of state laws that are in place now. Arkansas was the first to put their state law in place and have the most restrictions lifted. And others that have followed suit also have restrictions that are being lifted every day. It's almost a weekly basis that we get updates. For all the states that have put in contract pharmacy protections, the manufacturers and pharma have filed lawsuits. And what we've seen is that both for those that have had final rulings come back within the courts, as well as those where we have had preliminary rulings within the case, that we have consistently had the rulings in favor of the state. This is hugely different from what has happened with the 340B statute and the cases that pharma has brought against the federal government in those cases. And so why is that, right? Like that seems counterintuitive. And the reason that we have had losses at with HRSA and the pharmaceutical lawsuits around contract pharmacy is the 340B statute is silent on contract pharmacy. However, at the state level, so far, it has been deemed that the states have the authority to regulate around the delivery of medications and around pharmacy, the law enforcing pharmacy operation within their states. So we have seen these consistent rulings coming back and in each of the litigations, again, whether it's the final ruling or preliminary.
I think the key part there that I just want to reiterate or call back out is that it's around the delivery of medications. The restrictions here are restricting or stopping the delivery of 340B priced medications to contract pharmacies. And I think that that's a shift from where the conversation was being had necessarily at the federal level, which was very much focused on the price of the drugs. And at this point, the price of the drugs still exists, but the delivery is what's being stopped or inhibited. And I think that that's what's been really successful at the state level.
Yeah, and part of the reason that the states are able to do that is because the statute is silent on delivery. So the states are able to take their traditional authority to regulate around delivery of goods and services within the state, and they've had great success there. The fun, not so fun fact about these state cases, right, the part that's getting spicy, is it's going to go to the Supreme Court. So one of the manufacturers has appealed the two rulings that went in the favor of the state of Arkansas to the Supreme Court. And so now the question is, will the Supreme Court hear it or not? What the manufacturer said was that there was a split ruling among the courts, and they took the fact that the state courts had ruled in the state and the circuit had ruled in favor of the state, saying that they could have these contract pharmacy protections at the state level. And then they said that the third and the DC circuit had ruled in favor of the manufacturers. But again, fundamentally two different cases, because one was about the silence of the statute on contract pharmacy and allowing a condition on the sale. The other, which has been around the state cases, is around delivery. And so they're two fundamentally different things. I am not a lawyer, and the justices in the Supreme Court will be much smarter than I am in legal matters. And so I think if I can see through the argument that they're making about a split court decision, the justices will be able to as well. But there are other fundamental reasons why the justices may choose to take this up at the Supreme Court, just the impact across the country, how it impacts both the healthcare system as well as the manufacturers, and may choose to take it up there. The interesting question will be, how will they rule? We've seen some different things. I think if we were appealing the third and DC circuit rulings to the Supreme Court, we would not find a good ruling there. I think that would come back and say statute's silent on contract pharmacy, therefore HRSA, the Office of Pharmacy Affairs, cannot pick up the pen and legislate, so we don't win. But because this is around state rights, I think that we will have a better chance of the Supreme Court giving us a positive ruling for the states, as well as if you look at the Supreme Court case that happened just a couple of years ago with the American Hospital Association versus CMS when they restricted their 340B payments. It's very clear that the justices that are on the bench right now have a strong understanding of the 340B program, have a strong understanding of the intent of the program, why it was there, how it supports the safety net. And so the combination of states' rights and a strong grasp of 340B may mean that if it does get there, we have a lot of hope.
With the success that the covered entities have had in the states that have passed legislation to protect against these manufacturer restrictions, what advice would you give for covered entities that are in states that haven't passed that legislation yet and are still feeling the full force of the manufacturer restrictions?
Yeah, I think that it's a great time to think about is this something that could happen in your state? Like Kansas is a great example of a state where they thought they could never pass the contract pharmacy legislation. One covered entity worked really hard, and lo and behold, Kansas was able to actually pass protections within their legislative session. And so, don't be discouraged by thinking it can't happen. One of my favorite mantras is no is the answer to every question you don't ask. So getting out there, working with your state legislation, making sure people come to see your health center or your clinic, that they understand how important this program is to the patients that you serve, to the community that you serve, and how these protections have been so beneficial in the other states that they have been put into effect. The other thing is we are starting to see some movement at the federal level. We've recently seen bills introduced in both the House and the Senate that have contract pharmacy protections, which would be really beneficial. And while many think that those bills may not see the light of day, what we do know is that if we're not advocating for them and making sure our representatives understand how important they are, that will be a self-fulfilling prophecy. So really encourage everybody to get out and talk to all of your state and federal representatives and your senators about how important this program is and the impacts that we have seen over the last 4 years to being able to serve our patients and serve our communities.
I think the other thing is to try to dispel some of the misinformation that they're receiving, that those representatives are receiving elsewhere, just about how the 340B program works and how savings are used, because having our representatives understand the program better puts us in a better place when we do have the conversations about potential legislation.
Yeah, the greatest myth that I hear, and I'm sure you do too, is that the discounted medications don't make it to the patients. And we know every time a restriction comes into place, we get calls from the health centers saying patients have gone to the pharmacy, they have had to leave without their medications because they are so unaffordable. Those are the stories to take to your representatives so that they understand that this is not a change without harm to the community.
If you're looking for a partner to help you navigate manufacturer restrictions, whether it be just managing the 340B ESP designations and claim submission regulations, keep staying on top of all the changes that happen every other day, it seems like, or looking into opening your own entity-owned pharmacy or seeing if you can optimize your entity-owned pharmacy to make more out of the 340B program there. We're here to help you. I'm happy to meet you where you are and work with your organization.
We meet with a lot of health centers who feel like they're too late or they haven't started soon enough. But every day that you haven't started, right, that's your opportunity to start. You're never going to have more opportunity than today. And so don't beat yourself up over not having something right now, but let's start working together to move forward and start improving your program so that you can care for your patients.